So I'm James Douglas, one of the fellows, not Freddie Mercury, as you might be thinking. I went to an excellent conference a few weeks ago where every talk started with photos of where people lived or the hospitals they came from, so I figured that's how we do things in Canada. I come from an area in Poole, which is home to the second biggest natural harbour in the world after Sydney. That little spot of land you can see on the corner here is known as Sandbanks. And due to a very clever marketing ploy in 2000, is now the fourth most expensive landmass in the world. And I live just up here, and Southampton, which is my main hospital, is about 20 miles this way. It's a nice place to live. We have a great time. And being in November, I just thought, what was I doing this time last November? And I was a week before my exit exams. And a lot changes in a year. So in a year, I've passed the exam, finished the thesis, had another baby, and now I'm out in Canada. So it's been a good year. So potentially less interesting. My talk today is on systemic therapies for urological conditions. Won't be in too much detail, but for those of you with exams coming up, these are drugs that I didn't know much about before I did my exam. They might be quite useful for you. And the rationale behind it is there's a grey zone developing between urologists and oncologists as to who should administer some of the newer therapies, which are very well tolerated by the patients. So traditionally there was no real argument between urology and oncology. We managed to try and cure prostate cancer surgically. When we fail to cure it, or patients have uncurable disease, we control it with LHRH agonists or antagonists and proceed through maximum androgen blockade, which will primarily be an intermittent androgen withdrawal, plus or minus withdrawal of steroids and giving steroids, etc. And then when patients failed that, we'd ask them to see the oncologist for consideration of chemotherapy, which is a high morbid procedure. Patients get admitted with neutropenic sepsis, and we're quite happy to let oncologists deal with that complication. However, over the last few years, it's now developing a grey zone between urology with the new drugs that have come out that are very well tolerated. Abiraterone and enzalutamide are given to men with metastatic castrate-resistant prostate cancer. Denosumab prevents skeletal-related events in patients with bone mets after prostate cancer, and Everolimus is probably a key drug as it's developing a role for AML's treatment, and we're the doctors who look after people with AML, so we may have to learn how to use it. And I'd argue you should use them or lose them. So to talk about abiraterone and enzalutamide in castrate-resistant metastatic prostate cancer, I'll just quickly, for the residents, run over the potential mechanisms of castrate resistance. Critically, really, is one mechanism is for tumour cells to produce their own androgen, which means that they can self-activate themselves regardless of the systemic androgen levels. Tumour cells can also increase the number of androgen receptors, which will cause downstream amplification. And androgen receptors can mutate, so they can be activated by alternative ligands, or even be activated by crosstalk with other intracellular pathways like AKT or MAPK. And finally, they're the truly androgen-independent cells that will multiply without the need for androgen, the neuroendocrine cells that Shu was talking about a few weeks ago. So abiraterone is the first drug we'll talk about. We need to know the steroidogenic pathway. Cholesterol gets converted down to pregnenolone, 17-alpha hydroxylase pregnenolone, and eventually down to testosterone. And the critical enzyme to look at here is CYP17, also known as 17-alpha hydroxylase. And you can see that if we were to block CYP17, we'd prevent the formation of testosterone, but also prevent the formation of cortisol. We need to bear that in mind when considering giving people medications to block CYP17. So it's given as its abiraterone acetate that immediately gets broken down to abiraterone, the active ingredient. It's absorbed with food. It's a selective inhibitor of androgen synthesis, and it blocks CYP17. So it has to be given on an empty stomach, and you can't eat for an hour after taking it. So that's where abiraterone will work in the steroidogenesis pathway. So the first time abiraterone was investigated was to look for patients who had failed docetaxel chemotherapy in metastatic resistant castrate-resistant prostate cancer. So this was an oncologist trial, and this was the De Bono paper. which randomised nearly 1,200 patients into prednisolone versus abiraterone plus prednisolone. And their primary outcome was overall survival. And the key point from this curve is that there's a 3.9-month increase in overall survival with abiraterone acetate. And this is true for all the participants. The overall survival was 14.8 months compared to 10.9 months. So next role was to move it forward in our treatment cascade to give it to patients who were chemotherapy naive, so metastatic castrate-resistant patients but who had not had chemotherapy. And this paper by Ryan looked at 1,000 men with castrate-resistant prostate cancer and again randomised them to abiraterone plus prednisolone versus prednisolone and placebo. And again you can see for the primary endpoints of radiographic progression-free survival and overall survival, abiraterone is significantly better. And the overall progression-free survival was 16.5 months versus 8.3 months. And when looking at the secondary endpoints, patients did significantly better, taking longer to reach PSA progression, fewer patients needed opioid analgesia, and patients took longer to progress to chemotherapy. So the safety profile is pretty much a well-tolerated drug, but there are a few main things we need to look out for. The main differences between the two groups are hypokalemia and hypertension. There was virtually no difference in the grade 3-4 toxicities, but overall 22% had some degree of hypertension compared to 14% for the prednisolone group, and 17% had hypokalemia. So due to these promising survival outcomes and PSA outcomes, the Canadian authorities gave permission to prescribe Zytiga for metastatic castrate-resistant prostate cancer prior to chemotherapy last year. These are the BC Cancer Agency's eligibility criteria. The first group are the post-chemotherapy patients, and the second group are the patients that we might be used to looking after in clinic, the ECOG performance status 0 to 1, who are either asymptomatic or mildly symptomatic from their metastatic castrate-resistant prostate cancer. So if we're to prescribe the drug, we need to know how to give it. It's pretty straightforward. Give 4 tablets, 1 gram once a day on an empty stomach. Have to remember to give the prednisolone because it's a CYP17 inhibitor, so we have to counteract the lack of cortisol. And if you're to miss a dose, you just carry on the next day. You have to monitor these patients properly. This can probably be coordinated by the family doctor, but when we see them in clinic, you need to keep an eye on the big picture. Serum transaminases and bilirubin need to be measured every 2 weeks in the first 3 months, but this goes up to monthly after the first 3 months. Blood pressure and potassium needs to be monitored every month. And I'm going to quickly run through these side effects because these are not things that we, although they're not hard, they're not things that we look after every day. Hypertension is potentially a significant side effect. Up to 21% of the patients got some sort of hypertension. For the arguments of abiraterone, we're talking about stage 2 hypertension. So systolic blood pressure of greater than 160 or diastolic greater than 100. If any patients have this, they need to have that treated prior to starting abiraterone. This can be done by the urologist or the oncologist if they like, or just refer back to the family doctor to start on first-line antihypertensive medications. Hypokalemia needs to be monitored. Up to 28% will get some degree of hypokalemia, but in terms of severe hypokalemia, only about 5% of patients, and even then most of these won't be symptomatic. But as you know, severe hypokalemia could lead to a flaccid paralysis, ECG changes. I won't go through the ECG changes, you'll all remember the U waves and the ST depression and prolonged PR intervals. But patients with grade 3 hypokalemia will need to be treated, and it's fairly easy to treat it with dietary supplementation. So the patient needs to be aware of the foods that are high in potassium, and also we should keep an eye on magnesium because magnesium is a cofactor for absorption of potassium. So patient just needs to be given an information sheet to know that there's high levels of dietary potassium in dried figs, avocados, nuts, and generally speaking, a couple of glasses of orange juice a day will do more than enough to keep the patient's potassium up. So I'll quickly mention drug interactions. In reality, this isn't too much of a problem. It inhibits hepatic enzymes, the CYP enzymes from the liver, and you should avoid co-administration with some of the CYP inhibitors. But having said that, the treatment is normally to increase the abiraterone dose. In case you've forgotten all of the CYP inhibitor drugs, this is a chart for you, but most of them we wouldn't come across, but beta blockers are quite common, as is tramadol. Everybody seems to know about avoiding grapefruit for the exam purposes, but generally speaking it's well tolerated. You don't really need to stop taking the inhibitors, just need to be aware of it. So because of its interaction with CYP inhibitors, if patients have severe pre-existing hepatic impairment, they should not have abiraterone. But for everybody else, mild hepatic impairment or even end-stage renal failure, there's no need to adjust for dose. So just to summarise, the important monitoring considerations are to keep an eye on their liver function tests every 2 weeks initially for the first 3 months. Potassium should be monitored monthly, and blood pressure and fluid status should be monitored monthly. The next drug to move on to is enzalutamide. Abiraterone works to prevent activation of the androgen receptor by preventing the formation of testosterone. Enzalutamide works to disable or block the androgen receptor. What I didn't actually realise before starting all of this was that bicalutamide is actually a relatively weak androgen receptor blocker. It's even a mild androgen receptor agonist, and because numerous trials have shown continued androgen receptor activation in patients with castrate-resistant prostate cancer, research carried on in this area, and this led to the development of enzalutamide, which is now the new androgen receptor antagonist drug. It has an affinity for the androgen receptor that's over 5 times that of bicalutamide, and as opposed to bicalutamide, it doesn't encourage nuclear translocation of the receptor and inhibits binding of the receptor to the DNA nucleus. Dosing is, again, straightforward and easy. It's 160 milligrams orally once a day, taken with or without food. I'll mention the side effects later, but it's very well tolerated. The main drugs that stood out for interactions that we had come across, again, were abiraterone, sildenafil, nifedipine, and oxycodone. And if there's no alternative to these drugs, the treatment is to increase the dose of those drugs. So again, it's quite a safe worst case scenario. So the first study to look at the role of enzalutamide, just like abiraterone, to look at patients who had failed chemotherapy. This was the AFFIRM study. It looked at nearly 1,200 men with metastatic prostate cancer after who had failed chemotherapy, and randomised them to enzalutamide versus placebo. And you can see here the primary and secondary endpoints showing an increased overall survival for patients on enzalutamide, a longer time to PSA progression, and a longer time to radiographic progression. I think it's worth noting that these are men who failed maximum androgen blockade, failed chemotherapy, and they've still got an overall survival on the standard therapy stroke placebo arm of 13 months versus 18 months. So again, bringing enzalutamide forward in the treatment cascade, for us, the next study was to look at enzalutamide for men prior to chemotherapy, so chemotherapy-naive metastatic prostate cancer patients. This was the prevail study, and this is the landmark study that may well lead to urologists prescribing this well-tolerated drug. Phase 3 double-blind study, 1,717 men with metastatic progressive high-risk prostate cancer from 207 centres around the world. Primary endpoints were overall survival and radiographic progression-free survival. And they also looked at the endpoints of progression to chemotherapy. And interestingly, the final overall analysis should be after 765 deaths, but they planned an interim analysis after 516 deaths. So they performed the interim analysis after 540 deaths, and the trial was stopped because the benefit of enzalutamide was so overwhelming. They unblinded the patients in the control arms, and everybody was given enzalutamide. So the data is from this time point. Just running through the groups, they're very similar. They're all at similar ages. They all had high risk glycinate disease, most of them. They all had very similar disease profiles, high PSAs. A significant number had bone disease. A lot of them had soft tissue metastases. And this is the Kaplan-Meier that stopped the trial early. At 12 months, 65% of the enzalutamide group had radiographic progression-free survival, compared to only 14% of the placebo group. And the results of this were true for all ages, races, and ECOG status or disease burden. The other primary endpoint was overall survival. I think with longer follow-up, these curves would be further apart, because patients with having failed enzalutamide or placebo proceed to chemotherapy. So a better surrogate was to look at how many patients progressed to subsequent therapies in the trial. 70% of the placebo group proceeded to some sort of chemotherapy, most of that being docetaxel or abiraterone, with only 40% of the enzalutamide group. So this slide shows the objective soft tissue response to treatment with enzalutamide. I think it's just very impressive to see that in this group of patients, castrate-resistant patients, that they still have nearly a 20% complete response rate to some of their soft tissue masses. So they're very still had hormone-sensitive disease. The next step for a lot of these patients is to go through chemotherapy, which is a considerable reduction in their quality of life. Enzalutamide delayed administration of chemotherapy by nearly 1.5 years, which is a good thing to do, but only if enzalutamide is well tolerated, which it is. These are the adverse events for the trial, which is essentially the same between placebo arms and enzalutamide arms, and in fact more patients discontinued due to adverse events in the placebo arm than they did in the enzalutamide arm. Side effects were common in this group of potentially quite sick patients, including fatigue, back pain, arthralgia, but there was no difference in the majority of the cases, but the ones to look out for were hypertension, with 13.4% of the enzalutamide group getting hypertension compared to the placebo group. So in conclusion for enzalutamide, it significantly reduces the risk of death. It significantly delays the time to progression of their disease. It's a well-tolerated oral medication, and it's a drug that, as urologists, we may be having to use a lot more in the future. So we have fantastic treatments for prostate cancer, but we know that by reducing testosterone will lead to adverse bone events, and it's our role as holistic practitioners to take all of this into account. And Denosumab is a drug that I'll quickly talk about, which again I think we're going to be starting to administer in the future. So in a time-dependent and dose-dependent manner, removing a man's testosterone will lead to osteopenia, osteoporosis. The cancer can metastasize to bones, it causes pain and can fracture. For the next few slides, we'll be talking about skeletal-related events. So the definition of a skeletal-related event is somebody who has a fracture, needs radiotherapy, develops cord compression or needs surgery to their bone. It used to include hypercalcemia, but that's no longer one of the skeletal-related events. Before talking about Denosumab, I'll just quickly tell us what the background drug that we use mostly is bisphosphonates, and this has been shown to increase bone mineral density in the hip by up to 7% at 1 year. It is associated with a risk of jaw necrosis, which is probably dose-related and time-related, and we don't know the best dose of bisphosphonate to give. So there was a randomised trial of zoledronic acid versus placebo, 643 men who also had supplementations of calcium and vitamin D, and the point of this trial was it did show a delayed time to first skeletal-related event in patients treated with zoledronic acid, and there's an absolute 11% difference between these two groups. But the drug doesn't come up at all. The drug I wanted to talk about was Denosumab. This is a relatively new drug, and is a monoclonal antibody to the rank ligand. It's administered via subcutaneous injection, and has a high affinity for the rank ligand, and doesn't seem to interact with the other similarly shaped tumor necrosis factor family proteins. So this explains how rank ligand works. In low levels of macrophage colony stimulating factor, rank ligand is an essential mediator for osteoclast formation, function, and survival in all trabecular and cortical bone throughout the body. The rank ligand is a small member of the tumor necrosis family superfamily, and it can be expressed in three forms. The soluble free form you can see here, it can be a transmembrane receptor, and there's a truncated form. It binds to the rank receptor and essentially activates osteoclasts, and the activity is therefore to prevent activation of osteoclasts. But interestingly, potentially for future research, rank ligand is also expressed in numerous tissues, including breast cancer cells, normal breast tissue, prostate cancer cells, prostate cancer bone mets, T cells, B cells. So the clinical relevance of that is not understood, but it's attached to lots of things. So Denosumab is a monoclonal antibody that binds to the rank ligand and inhibits osteoclast formation. By doing this, it prevents bone resorption and will actively increase bone mineral density. Prostate cancer cells produce growth factors that stimulate osteoblasts to produce rank ligands, and this leads to increased osteoclastic activity and is one of the mechanisms behind metastatic bone fracture. So Denosumab will block all of these pathways. So the first trial to look at the role of Denosumab was by Smith et al. In 2009. This was known as the fracture prevention study. It took nearly 1,500 men on androgen deprivation therapy but with no bone metastases. They all had evidence of reduced bone density with a t-score of less than -1. They were randomised into 60 milligrams every 6 months of Denosumab, and the primary endpoints were bone mineral density and new vertebral fractures. At 2 years, the Denosumab arm had a 5.6% increase in their bone mineral density, and there was a 1% decrease in the placebo arm. And the secondary endpoints, there was also increases in bone mineral density in the total hip, as well as the femoral neck and distal third of the radius. New vertebral fractures were higher in the placebo arm at 3.9% versus 1.5% of the Denosumab arm. And it was well tolerated. There were no reported jaw osteonecrosises, but this was the 6-monthly 60 milligram dose. So Smith carried on and he went in to look at the role of Denosumab to prevent the formation of bone metastases in men with high-risk prostate cancer. All patients were advised to have calcium and vitamin D supplementation, and the primary endpoints was bone metastasis-free survival, with the secondary endpoints of time to first bone metastasis and overall survival. And it can be seen that the time to bone metastasis was longer in the Denosumab arm, and the curves continued to separate over time. This is the time to first bone metastasis, but the curves are pretty similar if you looked at bone metastasis-free survival. So to summarise this trial, it showed that Denosumab did increase bone metastasis-free survival by 4.2 months when compared to placebo. There are no differences in overall survival. You can't see it here, but the adverse events were similar, but with this higher dose, these people are getting monthly injections rather than 6 monthly, 120 milligrams. They're getting 2% had hypocalcemia and 5% got osteonecrosis of the jaw, significant side effect. And the final excellent paper on Denosumab was by Fizazi et al. In 2011, comparing zoledronic acid to Denosumab for treatment of bone metastasis in men with castration-resistant metastatic prostate cancer. And it was 1,200 men, nearly 2,000 men, and they all received calcium and vitamin D supplementation and randomised into 120 milligrams every 4 weeks of Denosumab versus zoledronic acid, with each arm being randomised against placebo. Primary endpoint was time to skeletal-related event, which was obviously pathological fracture, radiation, or spinal cord injury. And you can see the Kaplan-Meier's show that patients receiving Denosumab had a longer time to first skeletal event compared to the zoledronic acid groups, which is an 18% risk reduction. This is the same slide but the other way around, including all all fracture-related events. So this trial was able to compare both drugs to each other, but also to placebo, which means that numbers needed to treat. We need to treat 3.3 men with bone mets with denosumab to prevent one skeletal-related event. It's also superior to zoledronic acid. We have to treat nearly 8 men with denosumab instead of zoledronic acid to prevent one skeletal event. These don't come up very well. The adverse events of interest really are about the acute phase reactions, osteonecrosis of the jaw and hypocalcemia that you can't really see. But essentially, patients who had zoledronic acid got much more acute phase reactions in the first 3 days, swelling of the injection site, systemic illnesses, which they did not like at all in the zoledronic acid group. But in the denosumab group, we had more hypocalcemia, and 2.3% had osteonecrosis of the jaw. And this table doesn't highlight, but is just to highlight that virtually all the patients who had osteonecrosis of the jaw had risk factors of poor dental hygiene, or they've been on chemotherapy, and these are patients we should be identifying prior to giving denosumab. So if you do see somebody with some of the red signs, red flags for poor dental hygiene, refer them to see a dentist before starting denosumab. So in summary, denosumab is superior to zoledronic acid in preventing and delaying skeletal-related events. There are notable adverse events in both treatment groups, but the osteonecrosis of the jaw is worse in the denosumab group. It can be administered as a monthly injection, and there's no need for renal monitoring and no need to manage acute phase reactions. And the final drug to talk about was Everolimus. And the reason I want to talk about Everolimus is it has a role in treating angiomyolipomas, which has a prevalence of around 1 in 300-400 people. And this increases to 80% of patients who have tuberous sclerosis complex. AMLs arise from perivascular epithelioid cells, and as the name implies, they contain blood vessels, smooth muscle cells, and mature fat cells. It's associated with constitutive activation of the mTOR pathway, and they can spontaneously rupture. That's why we worry about them. You can get flank pain, Wunderlich syndrome, hematuria, hemorrhagic shock, and potentially renal failure if patients have numerous AMLs requiring treatments. For those of you with your exams, you can identify there some muscle and some blood and some fat. And that's a CT of somebody with a left-sided renal tumour, and you can see the hypodense fatty portions, which are pathognomonic of angiomyolipoma. So we generally manage these people with observation if it's less than 4 centimetres because of the morbidity of treatments. They'll grow about 5% per year, but if people have tuberous sclerosis, they have a much quicker growth pattern. If they get bigger than 4 centimetres, we all know that intervention is then recommended due to the risk of bleeding. And the treatments we have at the moment are embolization, partial or total nephrectomy, and maybe there's a role for Everolimus. Background of tuberous sclerosis complex is it's an autosomal dominant disease that affects 1 in 10,000 live births. It's a mutation of the TSC1 gene on chromosome 9, or TSC2 gene. Patients have the typical facies that you can see here of hamartomas in the CNS, skin, eyes and kidneys. Patients tend to present with what we call fits, zits and twits and zits. And about 20% have renal cysts, up to 80% will have AMLs, and there's an increased risk of renal cell carcinoma. So the products of TSC1 and 2 genes are hamartin and tuberin, and these complex together to block the mTOR pathway. The mTOR pathway combines with other proteins from the complex, known as the mTOR 1 or 2, and the mTOR pathways interact with numerous intracellular pathways, which leads to uncontrolled cellular proliferation and growth. And this is what is significant in tuberous sclerosis complex. So this just highlights what's going on in the cell. So Everolimus is the drug that will work to help in this situation. It's a rapamycin derivative which acts as an mTOR1 inhibitor. It's currently used widely in medicine. It's used for immunosuppression for transplant patients, advanced renal cell carcinoma, HER2 negative, brain tumours, subendomal giant cell astrocytomas, and it's also the active components of some drug-eluting stents. So we have a lot of clinical experience in using it. It's a once daily oral tablet which can be taken with or without food. Again, the CYP inhibitor enzymes should be avoided. You need to monitor LFTs closely. It's known to be teratogenic, but there's no need to monitor it to change the dose with renal failure. And because it's immunosuppressive, you need to avoid live vaccines. So the EXIST study was an international multi-center randomized double-blind placebo trial to look at the role of Everolimus in AMLs in these high-risk patients. And the patients were randomized 2-to-1 to receive oral Everolimus versus placebo at 10 milligrams once a day, and it was continued until the AML either progressed or there was unacceptable toxicity or the trial was finished. So at week 24, at least 42% of patients had more than a 50% reduction in the size of their AML. 80% had at least a 30% reduction. And this graph is just showing the Everolimus treatment group taking significantly longer to progress. There are only 4 events in the Everolimus group. And I'm not showing the data here, but every patient with Everolimus who got a response had a durable response that continued and nobody progressed after they'd developed an Everolimus response. So the patients who progressed here were the non-Everolimus responders. Also, the patients with tuberous sclerosis skin lesions saw a dramatic response in their skin conditions. However, there were some significant side effects, and these were mainly in the form of mouth ulcers and stomatitis. There were 4 grade 4 toxicities in the Everolimus group. These were 1 hypertensive crisis, 2 blood test results, which was a high uric acid, and neutropenia, and the final one was a convulsion, which apparently did result in death, but that was in a patient who had uncontrolled status epilepticus for most of his life, and it was hard to put that death down to the drug. As I said, it's used in many other conditions, so there were a lot of side effects that didn't come out in that trial that we need to know about, the main one being non-infectious pneumonitis. It is normally self-limiting if you stop the drug, and normally you just have to reduce the dose. There's an increased risk of infection, oral ulcers, decreased wound healing if there's surgery, renal failure, and again, avoid live vaccines, and it's teratogenic. So Everolimus is a TORC1 inhibitor. It's an effective treatment for patients with AML secondary to a tuberous sclerosis complex. It may improve long-term renal function and morbidity associated with numerous surgeries for these patients. It's well tolerated, and I think we need to know how to administer it. So just a quick case report to run through, courtesy of Dr. So. A patient of his a few last year, I think. It was a 35-year-old man with tuberous sclerosis complex. He had the typical facies of angiofibromas, had previous brain tumours treated, seizure disorder, retinal hematomas, and bilateral AMLs. He'd had 4 episodes of gross hematuria in the past, which had been managed with embolization since the age of 17, and then there's a lot of adolescent boys was lost to follow-up, and then presented 18 years later with flank pain on the right-hand side, weight loss, anorexia, fevers and fatigue, and was investigated as CT abdo-pelvis for contrast. So there's a little video to run through, which is quite quick. But essentially he's got bilateral large AMLs, and on the right here he's bled down here. And you'll have to take my word for it, but the CT demonstrates a 27 centimetre AML replacing the right kidney and a 12 centimetre left AML. On the right side there's also a 7 centimetre enhancing mass, which is well circumscribed and concerning for a renal cell carcinoma. So Rez is our chief, so I'm not sure what Reza will do next. Yeah. Yeah. it's a difficult situation, but he is, yeah. So doctor agreed with that, so he did a right open radical nephrectomy. Apparently it took 90 minutes, minimal blood loss. Pathology revealed AML with areas of transformation to epithelioid AML, which is a separate talk, but essentially epithelioid AML is a small subgroup of AMLs that have a high malignant tendency. We don't really know what to do with them. So the post-operative management of this man is difficult. He's got an epithelioid AML that we don't really know how to follow. We've taken it out, but how do we follow him up? He's still got a 15 centimetre AML on the left-hand side, and his current EGFR is 62. So it was discussed with the patient that he's got risks of spontaneous hemorrhage, local embolization for a tumour that big has failed in the past and may not do enough, and we need to preserve as much renal function as possible. So Dr. So contacted Novartis for compassionate release of Afinitor, trade name, and this was started. It was well tolerated. He didn't have any hypertension or fatigue. He noticed a big improvement in his facial angiofibromas. Initially his liver function test went off, but then normalised, and then he was followed up again 6 months, a few months ago. These videos are all too fast. But essentially, his tumour has got smaller. Right side is much smaller. So anyway, so reduction 30% the size of his AML. So we know it's effective treatment, but there's a lot of questions that still need to be answered. We don't know how long he should stay on this treatment. It's still about 10 centimetres, so still a high risk of bleeding. Is his bleeding risk really reduced? So I guess time will tell. So to summarise, we've talked at length about 4 systemic drugs that are well tolerated. Enzalutamide and enzalutamide is a drug that I think in the future we're going to be using probably in our everyday setting for maximum antigen blockade. I can't see a reason not to give it over bicalutamide, so we need to get used to that drug. Everolimus is the only medical treatment for AMLs, and we look after patients with AMLs, so we're going to have to learn about that as well. They need minimal monitoring, and that can mainly be performed by the GP. And my question is, who should be giving these drugs? Should it be the oncologist or ourselves? So I'd like to thank everyone for listening, and Dr. So for a few of the slides and the case report. Any questions?